One, please start, sir. We are.
Yeah. So, good evening, speakers and everyone joining with us today. It is a genuine privilege and honor to welcome you all to the Buyer Eyesight meeting. Today, we are conducting this meeting on DME. So, our first topic is visual outcome in DME, accessing in efficacy of Q16 aflibercept injection. And our speaker is Dr. Manav Jyoti Barman sir. Sir is a senior VA surgeon of ASGI Hospital, Guwahati, and he is also a ocular oncologist. He has more than 20 years of experience. And today's our second topic is case-based insights, aflibercept in managing DME. And the speaker is Dr. Debdulal Chakraborty sir. Sir is a senior VA surgeon from Disha Eye Hospital. Sir has more than 62 publications and almost have the all individual experience with the publications, and is a very renowned name in the Kolkata. So thanks all. There's the inside. There's a just welcome note from the buyer's side. So now the session is handed over to Manav Jyoti sir. Sir, now you can start.
Thank you so much. Thank you.
Thanks.
So thanks for inviting to the meeting, and there is a great privilege to be part of the meeting, rather. So
Sir, your slide is visible, sir.
okay.
Okay, you can have, yeah.
Yeah.
You can start, sir.
This. Okay. So it is full screen or?
Yes, sir. It is full screen, sir. It is full screen. Just check, sir. It is changing or not?
Yes.
Because it is from the start. It is only showing the first slide.
Is it okay?
Yeah, is it okay, sir? It is okay.
Okay. So good evening to all. So we are going to speak on the visual outcomes in DME, assessing the efficacy of Q16 aflibercept injection. So thanks, Bears, for the opportunity again. So it is expected that the global burden of diabetes will continue to increase, as all of us are aware about the situation all over the world. So the proportion of patients with diabetes who have sight-threatening diabetic retinopathy is expected to increase alongside the rising diabetic population, as it is seen that in 2020 it was around 28.54 million, whereas it is expected to be 44 million by 2045. So it is a huge number of population is going to be affected. So vision loss is the most feared complication among the patients of diabetes. So when the diabetic patients are surveyed, so it is seen that most of the patients are much more worried about the vision loss complications in comparison to other conditions related to diabetes, like the cardiac, renal, circulatory, foot, leg related or other complications. Effective treatment options provide the opportunity to improve the independence, productivity, and ability to perform daily functions, like regaining or maintaining a visual acuity of more than 20/40. The patient it helps to retain their driving license, reduce risk of mental illness compared with vision less than 70-80 years later, and potential for dramatic impact on patients' daily lives. So the efficacy of aflibercept treatment in diabetic macular edema is supported by the evidence of from the robust clinical trials. As already in many previous discussions we have discussed about the VIVID and VISTA and DRCR.net protocol T outcomes. So these are the robust studies that support the usefulness of aflibercept in the management of diabetic macular edema. So while VIVID and VISTA compares role of aflibercept with laser, this protocol T compares the role of aflibercept with other anti-VEGF like ranibizumab and bevacizumab, and Both these studies have shown superiority of aflibercept over the other treatment protocols. So endurance is the continuation study of the VISTA study. Rather, it is the patients from VISTA maintained visual acuity gains for 5 years with a mean of 3.4 injections in the year 5. So while the VISTA study patients were studied for 3 years, the endurance patients were studied with a follow-up of 5 years. So the international recommendations and guidelines recommend the usefulness of aflibercept in diabetic macular edema. Aflibercept is considered to be the drug of choice in DME eyes with baseline visual acuity below 69 letters, as it shows superiority to bevacizumab over 2 years and over ranibizumab in the first year of treatment in this protocol T. In patients with poor BCVA that worse than 612, aflibercept may lead to more rapid visual acuity improvement than ranibizumab over 1 year, although the difference was not statistically different by the year 2. Superiority of aflibercept was noted in the group of participants with worse baseline visual acuity, which this superiority of aflibercept at year 2 with gains of 18 letters in aflibercept, 13.3 letters in the bevacizumab, and 16 letters in the ranibizumab group in 2 years. And there is evidence for a possible difference in drug efficacy in patients with DME to the disadvantage of bevacizumab at a visual acuity of less than 20/50. Aflibercept is recognized as a standard of care in DME and is being used in multiple DRCR retina network protocols evaluating anti-VEGFs in DME, like the protocol W, where intravitreous anti-VEGF treatment for prevention of vision-threatening DR in eyes at high-risk patients. Protocol AB, intravitreous anti-VEGF versus prompt vitrectomy for vitreous hemorrhage for the PDR. And protocol B, treatment for central involved DME in eyes with very good visual acuity. And protocol T, already we have discussed, comparative effectiveness of study of intravitreal aflibercept or bevacizumab ranibizumab in DME. And protocol AC is a randomized trial of intravitreous aflibercept versus intravitreal bevacizumab plus deferred aflibercept for treatment of central involved DME. So these are multiple this DRCR protocols. They are studying the role of aflibercept. There is another study, the Violet study, that it is a multi-center open-label randomized phase 3 study to evaluate the efficacy, safety, and tolerability of 3 different treatment regimens of aflibercept 2 mg in patients with DME previously enrolled in the AQUA study. So aflibercept 2 mg 8 interval versus aflibercept PRN, and aflibercept 2 mg at 8 treat and extend regimen. So primary endpoint was the mean change in BCVA from baseline to week 52. And secondary endpoint was the change in BCVA from baseline to week 100 and change in CRT from baseline to week 52. The Violet study shows that gains achieved in the pre-Violet phase were maintained in the long term with a reduced treatment burden in the extended regimen group. The results from the 2 mg 8-week extended regimen group confirmed that this posology has a similar efficacy to fixed and PRN treatment regimens, while markedly reducing the number of office visits compared with the PRN treatment regimen in Violet. So in the aflibercept, this 2 mg 8-weekly fixed dose, we can see that office visit was 16. And aflibercept 2 mg 8-weekly treat and extend, it was 13, and aflibercept PRN, it was 25. So another study, the VBIM study, this prospective multi-center single-arm study assessing the efficacy of a treat and extend regimen with aflibercept in patients with DME over 104 weeks. This is the primary endpoint that aflibercept 2 mg 4-weekly for 5 months followed by individualized treat and extend regimen. The primary endpoint was a mean change in BCVA from baseline to week 104. And secondary endpoint was a change of BCVA from baseline to week 52. So this shows the treat and extend with aflibercept initiated in year 1 is a clinically meaningful visual outcome for year over year 2. 57% of patients were on 12-week or more than 12-week treatment regimen interval at the end of year 2. Another study by Hirano et al. This is a prospective multi-center open-label single-arm study assessing efficacy of treat and extend regimen with Aflibercept in patients with DME over 2 years, and Aflibercept 2 milligram 4 weekly for 5 months, followed by individualized treat and extend. The primary endpoint again mean change in BCVA and CST from baseline to 2 year, and secondary endpoint was the mean injection number, treatment interval distribution, and age by year 2. So the majority of patients with DME achieved 1 week treatment interval with an individualized treat and extend regimen with Aflibercept initiated in year 1. 66% of patients were on 16 weekly treatment intervals at the end of year 2. Another study, the Z study, 52-week single-arm prospective phase 3B study evaluating the treat and extend regimen in patients with DME across 5 study sites in Taiwan. Primary endpoint was the mean change in BCVA from baseline, and secondary endpoint was the mean change in CRT from baseline proportion with dry retina at week 20 and 52. So the Z study, this Aflibercept treat and extend initiated after 5 monthly loading doses provided significant visual acuity improvement in patients with DME. So 89% of patients had an injection interval of 12 weeks or more. So this in the prospective clinical trials, the majority of patients with DME they achieved more than 12 weeks treatment intervals after 2 years of proactive treatment and extend with Aflibercept. While the VBM study shows this is 9.4 letter change in that year 2 that Hirano shows 6.1 at the year 2, end of the year 2. So 57% of patients with in the VBM study maintained vision with at 12 weekly interval dosing, whereas the 66% of patients in the Hirano study 16 weekly dosing interval was found to be optimum at the end of the year 2. So in summary, Aflibercept can achieve clinically meaningful vision gains for maintaining vision regardless of baseline vision, and is the treatment of choice particularly for patients with baseline visual acuity of less than 69 letters, that is less than 20/40. So it is the only bispecific VEGF fusion protein that is designed to trap VEGF and PIGF. Early intensive treatment followed by treat and extend regimen in DME can also maintain vision with reduced burden to patient and clinic. Early intensive treatment of DME may maximize vision gains in the first year, and these can be maintained in the long term with a reduced treatment burden. Patient factors beyond baseline vision, such as duration and control of diabetes, can also have an impact on risk of vision loss in patients with DME. With proactive individualized dosing, patients can maintain visual acuity gains with a reduced treatment burden after year 1 with Aflibercept. Overall, early treatment of DME with good systemic control of diabetes and regular follow-up, a patient can maintain vision for a long period of time. And emerging real-world studies in DME have shown that Aflibercept leads to good visual and anatomic outcomes in clinical practice that are consistent with those reported in clinical trials. So thank you very much.
Thank you, sir. Thank you for a very insightful presentation. I think it will be very helpful for our audience. So now the session is open for the audience. If anyone have any questions or any query to the sir, so you can write down in the chat box or you can ask to sir. So if there is no query, I think it is good we can now move to our second topic. So I'm requesting Dr. Debdullal sir. So please, now the session is hand over to you. So at the end of the session, we can continue with the discussion or we can take the questions. Thank you.
Thank you, Abhishek, and really nice to share the platform with my very close friend, Dr. Manavjyoti Burman. We spent some of the best times in our lives together, and it's always a pleasure to see you whether virtually or meet you or virtually or
every time
physically.
We get to learn something new from you.
Actually, The new part you have actually told, so I will just try to sort of re-emphasize what you have told, and so I'll share my
Will-
slides. And
So
very good evening to
correlate the theory part with the clinical part rather to
right,
complete
right.
the session.
So yeah, and some of it will be a little bit of overlap. So I thought just to bring things into context. So let me share my slides. Okay, so are my slides visible?
Yes, yes, sir. Your slide is visible, sir.
Okay. So basically, why this is important, this presentation is important, this talk is, today's discussion is important rather, is to understand that where we stand vis-a-vis diabetic retinopathy in the country. So India performs 8.5 to 9.8 million cataract surgeries annually. The highest in a year was probably around 23, 24, for which data is available on the net. And needless to say, it is one of the highest volumes of cataract surgery that is done globally. But this is very satisfactory, something very satisfactory for all of us ophthalmologists or people associated with ophthalmology in the country. But needless to say, we have to do more, and as we go along, we have more ophthalmologists in India, and that is how we will be crossing these numbers and doing much more to serve the country. But having said that, what is worrisome is this. As of 24-25, an estimated 101 million people in India have diabetes. So this is not something nice. And what it essentially means for us ophthalmologists is that diabetic retinopathy is going to increase, and it has increased, and approximately 12 to 16% of people with diabetes have diabetic retinopathy, and 3.6 to 4%, that is 4 to 6 million roughly, very roughly, are suffering from vision threatening diabetic retinopathy. So that is where the ophthalmologists come in. As also, patients not having vision threatening diabetic retinopathy, the ophthalmologists have to play a very important role, because screening of these patients and timely advice to these patients is something very important. So keeping this in mind, we move on to the actual topic. So I'll be speaking on aflibercept in managing diabetic macular edema, and evidence-based approach. Some cases also I will show. So how do you decide how to treat center involving DME, or when to treat center involving DME? So there are 3 decision steps. One, is the patient having good vision? Good vision in the sense 6/9 or better. So in such situations, it has been noted that you can watch these patients, observe these patients, ensure that there is tight blood sugar control, and then as you go on observing these patients, subsequently you can decide whether to treat them or not. Now, when you have something like a vision which is less than 6/9 or maybe 6/9 with significant edema, then of course it is time to treat these patients. So what is the first line of treatment? Basically, needless to say, all of us do agree that anti-VEGFs are the first line of treatment. Now, which anti-VEGF? We will go on with all these, and we will maybe come to something subsequently. So it is also important to note that when we start treatment with an anti-VEGF, sometimes it is not working. And when it is not working, it is important to realize that we have to switch. And it is important to realize which is persistent fluid, which is a patient which is absolutely not responding, and we need to think when to change these patients to a better drug. So like I was mentioning, good vision CIDMA does not need active injections, because the protocol V tells us that if you treat these patients with aflibercept or laser, or you have these patients under observation, the effect on the vision is more or less similar over a period of 2 years, and these patients actually do well with observation only, provided these patients have good diabetes control, and one very important thing here is that only an OCT should not be the guide to force, you to treat somebody with whatever drug, be it anti-VEGF or steroid or whatever. So it is very important to realize that you have to observe also some patients, and if they are having very good vision, maybe 6/9 or better vision. But actually, the Indian context is entirely different. And most of our patients, when they come to us, you will be seeing something like this, as you have noticed in your clinics, or something like a OCT picture like this. So a lot of edema, poor vision, many of them having vision in the range of 660, 636, or even less. And 6/9 or 6/6 vision in a diabetic patient in India coming to your clinic is probably a rarity. So we have to really put the pedal hard on the accelerator, so to say, and treat these patients very aggressively and very closely, so that these patients actually stand to gain some vision. So there's need for fast rescue. More or less all of these patients have a very high fluid burden, and there is need for durable planning so that these patients actually do well over time. You have to think not only about diabetic macular edema, you have to think about the regression of diabetic retinopathy as well. So that is something that is very, very important when you are planning to treat diabetic retinopathy or diabetic macular edema. Now, Dr. Manav has already mentioned about these studies, but I would like to talk about these studies in a different context. So this is the Rise and Ride study. This is of course with ranibizumab, but subsequently when you have the newer studies, say Yosemite, you have Kite study and so on. So one thing is common in the newer studies. What is that? The use of aflibercept. So everybody is sort of trying to find out whether a new drug is as good, I would like to put it under inverted commas, as good as aflibercept or not. So same for faricimab, same for brolucizumab, all are trying to find out whether this is good enough as aflibercept. So very important point to remember. Dr. Manav Jyoti has spoken about Vivid and Vista, and you can see visual acuity improvement, is in the range of 11 letters, 10 letters with aflibercept, depending on what kind of regimen you give to the patient. And of course, one can tell that, okay, these are industry sponsored studies, but what about DRCR.net Protocol T? So this is probably one of the most important, one of the benchmark studies, which actually showed that there is a lot of difference when it comes to treating with aflibercept as compared to ranibizumab or maybe bevacizumab. Bevacizumab, of course, is off-label, and you have to have your ideas very clear on this. That if there is a litigation with having used bevacizumab, then it's very difficult to justify why you are using this drug when you have on-label drugs, so to say. So if you look at the Protocol T study, the mean change in visual acuity over 2 years, the area under the curve analysis shows that aflibercept is almost streets ahead right from 4 weeks. So at any given point in time, there's a lot of difference between aflibercept and ranibizumab and bevacizumab. So bevacizumab never catches up. There are there are assumptions and there are beliefs that if you keep on treating these patients over a period of time, then maybe they will catch up. But actually with ranibizumab also at 2 years also there's a lot of difference. So these are patients, remember, diabetic macular edema mostly affects patients who are in the working age group. So it's very important for these patients to get back vision immediately, as soon as possible, and go back to work. And the other important thing is, once they are more or less stable, they have to be at their workplace more often than not, and actually spend less time with you or me as as physicians or ophthalmologists. That's what I mean by you or me. So because these are patients who are in the working age group, they do not cannot afford long periods of leave or taking leave every now and then for getting their eyes treated. So this is where actually aflibercept can make a difference. Now the other important thing is, when you treat these patients with aflibercept, the necessity of rescue laser is actually lesser in the group with aflibercept. This is of course again protocol T I'm mentioning too, subsequent to what they were treated with. So basically, with aflibercept, you have the least number of patients requiring laser, rescue laser, or focal laser, as compared to ranibizumab or bevacizumab. Now, the endurance study has already been spoken about, but what is important is that as you go along treating these patients with aflibercept, the number of injections actually decrease, and the patients have a stable, kind of retinopathy, and macular edema stabilizes, and you can expect to treat them with 3.4 injections in the year 5, even earlier also. These numbers, I must tell here, is that uh, uh, the the numbers that we have in India are slightly lesser actually when you treat these patients over a longer period of time, primarily because we see cases which initially are not doing good, and then they reach up to a stage, and then these patients have. We are a country where we see these patients on a PRN basis in the sense that we actually observe and extend. So we keep observing these patients. Most of us keep observing these patients at monthly or 6 weekly intervals or 8 weekly intervals, definitely, and then we decide whether to treat or not, meaning thereby that if we have the slightest opportunity of not treating these patients, then these patients actually get lesser injections, and the patients actually are able to save a lot of money, which is very important in the Indian context. So there is substantial reduction of treatment burden as treatment progresses in these patients, provided the patient is aware that diabetes has to be controlled. Now, why actually aflibercept fits the bill? Because diabetic macular edema or diabetic retinopathy is not a VEGF only disease. So you have lots of factors that, inflammatory factors, etc., that play a part in diabetic macular edema and diabetic retinopathy. And placental growth factor is something that is aiming upstream at preventing leakage, edema, diabetic retinal vascular activity, etc. So when you have a combination of a VEGF blockage and placental growth factor blockage, then you have lesser amount of leakage, lesser amount of edema, and of course lesser amount of vision loss. So aflibercept is something that is a step ahead of the usual VEGF anti-VEGF agent that we are using. Now, all of these, are spoken of by RCTs, and we tend to believe that RCTs actually do not show the true picture. Absolutely, RCTs do not actually show the true picture, because there is a lack of selection of patients having been part of many phase 3 trials, phase 2 trials. I can vouch for it. Dr. NJB is also part of many phase 3 trials, many phase 2 trials, and all of us, have realized with these, trials that we have performed, that the selection criteria is very, very restricted. You cannot, so to say, take up, really bad patients, which we, have to treat in the real world day in and day out. So results may not fully reflect the real world complexities of disease and its management. And that is where the real world data is necessary. It measures real world effectiveness in the clinic. Patient population, of course, in the real clinic is unselected. Treatment is based on your decisions, the physician's decisions, and typically it includes a diverse outcome measures. So you're not hiding anything, and it is not a bed of roses only sort of a picture. So Dr. NJB has already spoken about all these trials, but one thing I would like to mention here is that aflibercept is a drug where in the real world also, with lesser number of injections also, you can expect to get good visual gains, whether it is the Apollon trial or the Moorfields data. And we actually published this article a little while back, wherein we compared dexamethasone implant in recalcitrant diabetic macular edema in pseudophakic eyes, mind you, pseudophakic eyes, with aflibercept. So what we actually saw was that intravitreal aflibercept had 6.5 times higher likelihood of providing the patient with more than 3-line improvement. So this is something very important, because The steroids, they can reduce the edema, but they can almost never ever, they can, bring about a regression in the diabetic retinopathy scores. So that is something that is very important, and you have to understand what is the importance of anti-VEGF in the field of treating diabetic retinopathy and diabetic macular edema in particular. Again, with dexamethasone group, you have higher IOP, which we also noted in this study. But this was a study where there were no phakic patients. We actually selected pseudophakic patients only to understand how different these two were in bad cases, recalcitrant cases, and how effective was aflibercept. So aflibercept actually came out trumps when it is given in the right context. Now, there have been publications from the VRSI group, the Diabetic Macular Edema Treatment Guidelines in India from the VRSI study group, and anti-VEGF therapy is more effective. It says anti-VEGF therapy is more effective in improving vision, in CIDME than macular laser treatment. So we are mostly not doing laser now for center involving DME. This is besides the point, but just to bring things into context, this is not a very old article. This is only 4 years old, 5 years old, 2021 October. So this is also something we have to remember, that when you see center involving DME, please do not think about laser first. You can do rescue laser if it is necessary subsequently. Now, the Cochrane meta-analysis reviewed evidence from major studies investigating efficacy of anti-VEGF agents in DME, and it found that at year 1, all efficacy outcomes significantly favored aflibercept. Patients were approximately 30% more likely to gain more than 3 lines with aflibercept, which has been our finding with our study. And for every 1,000 people treated with aflibercept, 92 fewer would gain 3 lines or more at year 1 if treated with ranibizumab. So this is not me telling, this is Cochrane, which is the sort of Bible of analysis, meta-analysis, saying things in favor of aflibercept. Now, if you talk about guidelines, Dr. Manav has already mentioned about all this. Aflibercept is the drug of choice in DME eyes with baseline BCVA below 69 letters, and as it shows superiority to bevacizumab over 2 years and over ranibizumab in the first year of treatment. So needless to say, most of our patients are in this category, and we actually need to treat these patients better. And of course, if you talk about APVRS guidelines, then also it mentions anti-VEGF therapy should be the first line of treatment. The choice of anti-VEGF agent depends on baseline visual acuity, and early intensive anti-VEGF therapy is important for patients in Asia, and needless to say, in India. So, today, durability is something that is, again, we are something looking at in a newer way. So we had Eylea, and we have Eylea 2mg, which is established today, and depending on which part of the world you come from, you can talk about 3 to 5 monthly loading injections, and then treat these patients at Q8 weeks, and gradually extend beyond Q8 weeks. But now the evolving global narrative is the aflibercept 8mg, which is soon to arrive in India, and the studies have shown that you can actually treat these patients up to 20-week with up to 20-week intervals after 3 monthly doses. So that is something that is very important. And of course, initially in the first year you might need more injections, but after 1 year of successful response, you can actually treat these patients at Q20, and there are some articles mentioning Q24 as well. So 6 monthly treatment, that is really interesting. The practical message here is Eylea is moving from efficacy to durability, and more importantly, capacity relief, because these patients actually need to stay at their workplaces, stay at their whatever they are doing, and rather than spending time with you and me. So this broadens aflibercept conversation beyond works well to works and scales. Now, so basically, you load these patients, you can maintain these patients on various intervals depending on how the patient is. You have to optimize, obviously, you have to check these patients whether they are doing good at whatever interval they are on, and then extend these patients to larger intervals. So from fixed monthly rescue to planned maintenance, individualized retightening, and extended durability is the new buzzword. So I'd like to finish with a few cases. So this is a naive phakic DME. You can see the disc shows a little bit of pallor. You have hard exudates here. almost a succinate hard exudate. Needless to say, subretinal fluid is there, 624 vision. So we start these patients with aflibercept and statins. So when I treat patients with DME, depending on how good or bad the patient is, I actually tell these patients that I'm going to see you after a month and then tell whether you need the next injection or not. And in most cases, a diabetic macular edema that is in bad shape actually needs loading dose. So for me, loading dose is 3 loading doses, unless there is some other issue involved. So initial treatment, aggressive treatment actually helps these patients a lot. So this is after the first injection, you can see the SRF is gone, the hard exudates because of the statins, it is going down. So you have to think about combination treatment. And this is the next injection. You have the clumping of the hard exudates in this region. This looks more or less the same, but you again one injection, and this is actually 3 months subsequent to the third injection. You can see the hard exudates have resolved. There is some amount of edema 3 months subsequent to the third injection. So this is Q12. So you can now you can treat this patient again. So another patient, naive patient with DME, you can see a lot of intraretinal fluid, hyperreflective foci, and this patient actually gets an aflibercept, and this is how things change. There is a resolution, some resolution of the intraretinal fluid. There's some SRF coming here, and give the next injection. There is some reduction again of the edema. The vision is gradually increasing, and the patient receives the third injection, and the patient looks a lot better. The OCT looks a lot better, and so also the fundus picture. Now this is 4 months after the third Eylea. You can see the fluid coming back. So 16 weeks, that is after the third Eylea, and then this is time when the patient should get an injection, and this is 4 months after the fourth Eylea. So you can see as time progresses, the edema coming back is lesser. So that is something that is noted a lot of times with Eylea, primarily because it actually brings about regression in the diabetic retinopathy scores. So here's a patient treated with another anti-VEGF. So initially, as you can see, after 3 anti-VEGF injections, this is a ranibizumab injection that we gave. This patient has an NPDR along with a BRVO, and not a very good response. So just see how effective aflibercept is. Just after 1 injection, there's a lot of reduction in the edema. The SRF has started decreasing, and the vision has also started improving. This is, of course, the fundus photo. The BRVO has reduced a lot, and you can see probably there's some regression of the diabetic retinopathy score also. So vision has improved to 6/9 partial. So this is actually how aflibercept can make a difference. Then, of course, some slightly difficult cases or difficult to sort of treat cases. This is a patient whom I advise focal laser with IVTA, and actually after 1 month of the IVTA, this patient actually had resolution of the edema to a great extent, but IOP shot up. So yeah, I had a tough time bringing down the IOP with a lot of medications, and subsequently, as the IOP got controlled, the central macular thickness started increasing, and this is how the patient actually looked when we had to shift back to ranibizumab. So lot of ranibizumab injections were given, and this is after 8 or more ranibizumab injections. Vision is 6/24. So this is when we actually got the patient to shift to Eylea, and after just 1 injection, there's a lot of difference that's happening. So this is 2 months post the first Eylea. You can still see some intraretinal fluid here, but the patient was feeling happy, and we did not re-inject. This is 3 months post the first Eylea. You can see the fluid coming back, but definitely at this point in time you have to retreat. And this is 1 month post the second Eylea. So this is a patient for whom I went PRN. So because patient has already taken a lot of injections, and it is difficult for patients to keep on taking so many injections. So Eylea is something you can use in the PRN mode also. So this is 3 months post the second Eylea. Again, just to re-emphasize, like I mentioned, as you go on treating patients with Eylea, these patients actually require lesser injections, and there's a regression of the diabetic retinopathy score. So here you can see diffuse edema, a lot of hard exudates here. So this is after 1 injection, and this is another this is actually ranibizumab injection. So this is how the patient was. So after 2 ranibizumab injections, I decided to do some focal laser. But see what happened after the focal laser. There was actually rebound edema, and it never really actually decreased. So patient had a government health scheme going for him, and this is after 12 ranibizumab injections, the patient actually could not get better. So at that point in time, under the particular health scheme, the patient was aflibercept was not available, but we somehow convinced the patient to actually shift to Eylea or aflibercept, and 2 months after the first Eylea, you can see the retina looks a lot better. The vision has improved to 6/9 partial, and this is 2 months after the second Eylea. So the retina is looking still better. There's some amount of intraretinal fluid here, and this is 2 months after the third Eylea. So depending on how the patient is doing, I tend to titrate my patients on anti-VEGFs, and you can see this patient is not a great patient to have, because there is FSZ distortion also on the octa. So this is a patient with POAG in the other eye, and this is a patient has hard exudates in the macula. So we gave the first Eylea in this patient, and this is what happened. There was clumping of the exudates in the fovea. So we added statins. You can see the Optos image also. There is clumping of the exudates in the fovea. The vision actually went down from 624 to 636. But it's very important to continue anti-VEGF in such situations when you cannot move to steroids. And of course, important to start statins. And this is how patient actually improve. This is after the second Eylea. We gave the third Eylea. Remember, statins were being continued, and this is 1 month after the third Eylea. Vision is now 6/18 partial, and as time goes on, the hard exudates keep decreasing. So we gave a fourth Eylea, and this is how the patient was 1 month after the fourth Eylea. We gave a fifth Eylea, and this is how the patient is improving. So over time, you can expect the hard exudates to actually go down if you use a combination therapy with statins, or your what you can give in consultation, something you can give in consultation with a physician friend. So another patient post vitrectomy, you can see a lot of edema. So we gave an aflibercept plus statins, and this is how the edema reduced. Gave a second injection, and a lot of improvement in the OCT. So you can see the hard exudates are also lesser or have decreased greatly, and the patient is doing better. So the closing message is, when you have patient with good vision, do not over-treat patient with any injection or maybe laser. And you have to acknowledge that when you are treating a patient with bevacizumab or ranibizumab, there can be failures. So it is important to appreciate that there can be failures with ranibizumab, bevacizumab, or for that matter, any kind of agent. And it is important to switch these patients. It is important to realize that steroids may raise IOP and cataract rates, and use aflibercept confidently when the vision is worse at baseline and the subgroup evidence is the strongest for across different studies. And do not let early persistent fluid become the same thing as therapeutic failure. So it's very important to treat these patients aggressively and let the patient benefit from proactive treatment. So aflibercept is one of the best answers for the right DME eye. Thank you for your kind attention. So I'll stop sharing.
Thank you, sir, for a wonderful presentation. So how elaborately you discuss every slide of your slide deck, it is really helpful for your audience for their day-to-day practice. It is help them to treat their patient in a better way. So now the forum is open for the discussion. So anyone have any kind of questions or any session, they can discuss with the speakers.
Dabdulal. Hello.
Yes, please. Yes, please.
Yeah. How frequently
Talk.
you use IVTA?
IVT, actually, I have cut down a lot because I've had some IOP rises, spikes, and again, to be very honest, I use some IVTA, but not to a great extent. Very, very few. It is probably less than 5% of my practice, even less. I think 2-3% of my practice. Only when all other options are exhausted, patient cannot take the biosimilars. Also, then I consider IVTA, keeping in mind the disc, etc. If there is a chance of IOP steroids. I generally do not go in for IVTA.
In post-vitrectomized eye, do it either anti-VEGF or Azuredex implant? Which one you prefer in general?
If it's if it's a vitrectomized eye, generally I prefer steroids, Ozurdex implant. But if there is a patient with, like I mentioned, this patient actually had other issues like raised IOP, etc. If that is there, the disc is looking ominous, or the other eye has raised IOP or glaucoma, then you have to think about an anti-VEGF at times. Having said that, anti-VEGFs, as all of us know, do not stay in a vitrectomized eye for long. So you have to repeat at a frequent interval.
In most of the cases, usually, if there is a good physical control, systemic control, I think one or two anti-VEGF, particularly aflibercept, is usually good enough for macular edema. No? What do you feel?
Yeah, if systemic control is good, then aflibercept, one or two injections really does wonders.
Yes,
But
yes.
if I feel that the patient can do better with a third injection, I do not hesitate to actually tell the patient. Many of the patients
Definitely.
cannot take,
Yeah.
so that is of course an issue.
Yes, yes. So some patients, bed patients may need multiple injections. That definitely aflibercept has a upper hand in all these cases. What I personally feel. But
Absolutely.
if systemic control is good, I think most of the patients don't need many injections, and laser to very few patients actually need for macular edema nowadays.
Absolutely.
Thank you so much, Abdullah.
Thank you, Manavda.
Very nice
It is-
cases actually you are showing, and each and every case has a good significance in clinical practice.
Thank you so much. And actually, as probably some of the friends here do not know, we have we started our retina career together, and treat fellowship, etc. We've done. So basically, your thoughts and my thoughts are somewhat similar. To a great extent, they are similar because of our common background.
Yes,
So,
yes.
that's how things are.
So basic teaching was the same.
Absolutely.
Yeah. Thank you all.
Yeah. So really, say thanks, Manav sir and Devdulas sir, for your valuable time, and also thanks to our audience for your presence. So hopefully we'll again try to engage this kind of organize this kind of meeting that will help our audience. So again, thanks from the core of our heart, from the buyer. Thank you, sir.
Thank
Thank
you.
you, Abhishek.
Thank
Thank you, sir.
Manavda.
From my side also, thank you, Devdulas sir and Manav sir.
Thank you.
Yeah,
Thank you very much.
Dhruva.
Good night, sir. Yes, sir.
Lockpump.
Lockpump,
Okay.
sir.
Good night.
Good night. Good night.
Bye.
Good night.
Good night, sir. Bye.
Good.
So I am requesting my tech team kindly stop this meeting link. Hello, tech team. Hello. Tech team, are you there?
Yes, sir.
Yes. So you can close the meeting link. Okay.
Okay, sir.
Thank you. Thank you for your support.